Welcome everyone. This is Dr. Sharad Jaitly from New York. Thank you for watching, learning, and sharing on your website, MuniMeterHealth.com, your favorite website dedicated to educate on human heart. I welcome you on my website with a new software that has been incorporated, as you see while I write on the screen. And this is MuniMeterHealth.com, which is your website currently dedicated for freely disseminating the information on human heart illnesses and its care. I thank you again for your enthusiastic support and a growing viewership across the globe. So without any further ado, the subject of the matter, as I always say, is the matter of the heart. And the matter of the heart today is mitral valve prolapse, also known as MVP. So here I'm going to be drawing while you're learning and you're teaching yourself. So let's see how I draw, and again, my sketch pen is a little slippery, and hopefully I will stabilize one day my new technology, the software that we have incorporated. So if you look at the heart being a four-chambered organ, you have the valve leaflets here, as you see, and these are the valve leaflets I'm trying to show you here. There are four valves, four chambers, as we know, and obviously we have the aorta coming out from the left side of the ventricle, which is the left ventricle here. And this is where the flow is occurring from, top chambers to the bottom chambers. It passes from LA to LV. This is your mitral valve, and that's the one in question. We'll be discussing that very shortly, and up into the aorta. So all the oxygen-rich blood, if you will, is going up into the aorta and spreading throughout the body. So as it spreads throughout the body, all of that oxygen is taken up by the tissues and every single cell of your body, and when it returns back, it comes back more deoxygenated, if you will. And that deoxygenated blood, next thing, goes through the pulmonary artery up into when the right ventricle pumps it, and then it sends it to the lungs here on either side, situated as you see. I'm drawing the lungs here. So the lungs will now receive the deoxygenated blood from the right side of the heart, and the CO2 is actually taken up into the alveoli, and then finally exhaled out in every single breath of your life, I would say. And the oxygen, the fresh oxygen, is now taken into the bloodstream. So as it is taken, that blood is returning back via the pulmonary veins into the left side of the heart. So, and the circulation just continues. So the oxygenated blood is on the left side for the student's sake, and I'm sure the rest of the people already know, but the deoxygenated blood is on the right side, if you will. Okay, and here I'm going to label the various chambers of the heart. Obviously, this is your right atrium. This becomes your left atrium. The top are the atria. These are the ventricles, right ventricle and the left ventricle. Left ventricle is also called the booster chamber. These are your valves. The tricuspid valve, the mitral valve is here. Remember, it's a bicuspid valve. This is a tricuspid. So it has three leaflets. This has two leaflets. And the rest of the valves all have three leaflets, if you will. So if I was to draw the aortic valve and the pulmonary valve here, they'll have three leaflets here as well. Okay, so it could be a magic question on a student trivia, where mitral valve prolapse is only the bicuspid valve, if you will. The rest of the valve leaflets are tri-leaflet. Now, the one in question is mitral valve prolapse we are discussing. So how do you define prolapse? Well, remember that when the mitral valve normally closes, it closes up to this point, almost up to the level of the annulus, but there is a certain amount of if you will call it a bulge that's into the left atrium permitted, which is within the 2 millimeter dimension. So anything less than 2 millimeter is still a normal variance, if you will, that the leaflets will sort of bulge within the left atrium. Now, given the fact these leaflets are very, very tender, very, very fine structures, so when the left ventricle forcibly contracts, some of the leaflets will bulge into the left atrium. That's a normal variance. So up to 2 millimeters is a given normal variance. Anything more than 2 millimeters is considered as abnormal. So just remember that. So when we see the blood is circulating and going from the mitral valve, if you will. This is the mitral valve, and when it bulges into your left atrium beyond 2 millimeters, that is by definition called mitral valve prolapse. Okay, so now let's understand what the clinical features of the mitral valve prolapse are. The clinical features of the mitral valve prolapse are chiefly, most of the patients are young, predominantly females, and the ratio being 9:1. In other words, you'll see 9:1 ratio for females to males. And so that's a pretty high incidence. And in the males, it tends to be very, very severe. So just remember, the prolapse progresses rather very acutely and more severely. And we'll talk about the severity in a second. So most patients will present with atypical chest pain, if you will. And then, of course, dizziness is a very, very common symptom because of the regurgitation that happens into the left atrium. Chest pain is usually because of the valve leaflets being anchored into the chordae and tendineae, and because these valve leaflets are a little more redundant and they are more curtain-like, they tend to bulge. Numerous phrases in English have been defined for prolapse, like a sail of a ship, a bellowing within the left atrium, if you will, or even the flail leaflet, if you will. That's a pretty dangerous type of mitral regurgitation where the valve leaflet just flails back into the left atrium in this fashion. So that causes severe regurgitation or worsening regurgitation. Now, so atypical chest pain, dizziness, shortness of breath normally is accompanied by 2 or 3 other things like called arrhythmias, if you will, especially the SVTs that can occur, or atrial fibrillation if it's present. Sometimes the LVEF is down, the ejection fraction is down. You could experience, somebody could experience a shortness of breath there in that setting. And thirdly, if the mitral regurgitation has worsened rather abruptly. So if it is changing course of mitral regurgitation, changing murmurs, those will be the signs of shortness of breath as well. So signs and symptoms, these are predominantly ones. Very rarely one will come across a syncope, and then again, any of the above 3 could be present. Palpitations are very common, but that's only in a setting where you have an arrhythmia. Normally, the palpitations are related to either a lot of APCs that occur from the left atrium, sometimes VPCs, and they could be well treated by beta blockers because that becomes the drug of choice in a mitral valve prolapse anyway, and you can hit 2 birds in a row. You can take care of the prolapse, and you can also take care of the arrhythmia as well, especially the supraventricular arrhythmias. Having said that, now let's understand what the pathophysiology is. The pathophysiology is very simple. The more the mitral regurgitation, more the mitral valve prolapse, the more will be the mitral regurgitation. Now, arbitrarily, it's been defined as the regurgitation by Doppler, color Doppler technique. If you were to do a color Doppler technique, say for instance here. Now, I draw a Doppler here for you, and this is how the heart will look like in a setting where you have heart being represented in a fashion which is inverse. Now, if you have the heart being represented in a fashion inversely like this, you'll see that the left atrium is here and the left ventricle is at the apex. So left ventricle is at the apex, left atrium is at the base, and as a result, some amount of regurgitation that can occur will start occurring here. So depending upon how far the regurgitation spreads, if the regurgitation is up to first third of the left atrium, it is considered as mild. If it is to the second half of the left atrium, it is considered as moderate. And then, of course, this being the severe when it hits the roof of the left atrium. So mild is here, moderate is here, and severe is here, depending upon where the color Doppler interrogation can sense the mitral regurgitation jet, if you will, in a setting of mitral valve prolapse. Now, commonly asked questions on the boards, just for the people who are preparing for the exams, etc. And these are nice trivias also for colleagues like me. So if you have a 21-year-old female, for instance, presenting with atypical chest pain, dizziness, shortness of breath, etc., which test would you order? I mean, they could put a question like that. Basically, they want to know whether you're going to order an echo or a stress test. Well, the chances are stress tests will only define if you have issues of coronary artery disease, but you're not suspecting that in 21-year-old female, obviously. There are no risk factors here, so it's an atypical chest pain. Plus, the person has all these features which are very suggestive of mitral valve prolapse or the click-murmur syndrome. So an echo should be the right choice here. Now, secondly, they might give you a question where there is, for instance, a 45-year-old male. Now, 45-year-old male presenting with all the above symptoms and all these symptoms here, and is a smoker. Now, on top of that, the patient is a smoker. They'll also give you a clue that there's a family history of a sudden cardiac death, or maybe perhaps a premature coronary artery disease in a young man having an MI, etc. in the family. So that 45-year-old male, you should do a stress test. That becomes the procedure of choice. Now, remember, mitral valve prolapse on your auscultation will have a click-murmur syndrome, and that's why it is defined also as a click-murmur. You'll hear mid-systolic click and a late systolic murmur in these individuals, besides all these symptoms, as I said. And so those are the sine qua non of, if you will, a click and a murmur, which will be diagnostic of mitral valve prolapse. Now, many times you may just hear a click, many times you may hear just a murmur, other times you'll hear both. Now, click-murmur syndrome was coined by Dr. Barlow, and Barlow was the pioneer, I would say, in, in South Africa, who actually started to listen and concentrate predominantly on those individuals who were presenting within their family, several siblings who had the clicks and the murmurs together. I had the opportunity of hearing him when he made a keynote speech actually several years ago at Cornell, where I trained, and turns out that this was all pre-echo era, where he was able to diagnose so conveniently the click-murmur syndrome by his clinical acumen. And therefore, with all the tributes, it's now also known as Barlow syndrome, if you will. So mitral valve prolapse is also known as Barlow syndrome, is also called, of course, click-murmur syndrome, as we call it. Okay, so in a nutshell, I've discussed mitral valve prolapse within the scope of this short video vignette. Hope you find it interesting and you gained something out of it. Please spread the knowledge. Please continue to spread the word to your friends, colleagues, and of course to the general masses. I'm sure they also pick up a lot of points out of this, because my goal is to educate freely to all, and this way we can contribute to the cause of spreading the knowledge here through MuniMeterHealth.com. Thank you again, and until then, so long, Dr. Jaitly.